हाँ हेलो। हाँ ठीक। ठीक है ठीक है ठीक। ठीक है ठीक है ठीक है ठीक। थैंक
Good afternoon, Patra sir.
Good afternoon.
So everything ready? Audio, video,
Yes,
and
yes.
classroom and other. Already I found the speaker and our director sir. Many of the members they have already joined. I think we should start at time.
हाँ, आप ज्वाइन कर लेना। हाँ हाँ, ठीक है। अब हम 3 बजे एग्जैक्ट 3 बजे शुरू कर रहे हैं।
Okay, fine.
हाँ,
Thank you.
ठीक है।
Hello and good day to India.
Hello. Good afternoon, Mr. Chris. Well, sir, shall we start now?
Come again, please.
Yes.
Yes, I think if
Yes.
it's okay, we can start.
Okay. So, good afternoon to all. Welcome, everyone. Thank you for joining us today's webinar. I am Aratatran Patra. I am the faculty of Department of Prosthetics and Orthotics at National Institute for Locomotor Disabilities, Calcutta. It is a great honor for me to introduce and welcome our director, Dr. Amit Iqbal. My sincere thanks to Iqbal sir for his gracious presence in this webinar. I welcome Dr. P.K. Lenka, HOD Department of Prosthetic Orthotics for his presence in this webinar. Today we have our guest, Mr. Chris. He is the CEO of Human Study. He is with us. I welcome Mr. Chris. I welcome today's speaker, Mr. Michael Rexing, a certified prosthetist and orthotist from Germany. He is an international trainer in spinal orthotics. He is a board member of Human Study Germany. I welcome Mr. Naveed Dabin, Physical Rehabilitation Program Manager of ICRC, and Mr. Anil Singh of ICRC. I welcome all the participants, faculties, and staff of Department of Prosthetic Orthotics. Today's webinar on conservative scoliosis treatment, a review of current techniques and approaches, is a very good, very interesting topic. I hope the participants will refresh their knowledge and may learn certain new things from Mr. Michael. Thank you all. I request our director, Dr. Amit Iqbal sir, to speak few words and inaugurate the webinar.
Thank you, Mr. Patra.
Sir, I think you are mute. We are not able to hear you.
Hello? Hello?
Yes, we are hearing.
Yes, of course. Thank you, Mr. Patra. Welcome. First of all, I must welcome Mr. Chris, Mr. Michael, Mr. Navid. We are delighted to have you all with us on this occasion. And I think that throughout this meeting, we'll be able to know a lot of things which will be helpful for us, for our students, for our faculty, and all that. I must congratulate our department for organizing this webinar, particularly the head of the department, Dr. Lenka, Mr. Patro for doing this arrangement and all that, and all the participants. I won't say too much about the scoliosis or too much about the conservative management of scoliosis, but I just want to highlight one or 2 points. From the clinician point of view, I'm a rehabilitation physician. So I think from our point of view, 2 or 3 things are very important. And from the point of view of the patients and the families, that we have been doing a lot about early detection of different types of disabilities, I would say. But I think that we are not very proactive till now, so far as our place is concerned, our country is concerned, regarding the early diagnosis of scoliosis. So why it goes neglected, or why we are not able to know it? Because there may be a few factors which I could gather, that most of them are females. There are a lot of children in some families in which the mother cannot pay attention to almost all the children equally, because usually the mother can see it, as most of the kids are females. as girls are more affected than males in case of idiopathic. So, and the type of dress they are using, there is less awareness. And one important thing is that usually in the beginning there are no symptoms. So these may be a few factors which lead to delayed diagnosis, and delayed diagnosis leads to delayed intervention and management, and some complications too. And it's difficult to manage at a later stage. A lot of has been said about observation. We always say observation, orthosis, and operation. So observation is very important, but only one thing in observation, that the child may be exposed to a lot of radiation risk, a lot of x-rays being done. So that has to be very judicious, because that itself is a risk. So we have to make a balance between the judgment of bracing over observation, because some parents have also been seen to go in favor of bracing rather than going for observation for a long time. I hope I'm not wrong. Then what we can do is do more and more awareness in the society about the problem, and let people know that yes, it is treatable, and it is easy to treat when diagnosed early. I think assessment should be done by trained people at the basic level, at the primary health level, in the family, with simple tools. So training of the basic health workers and awareness in the society is very important, so that these cases can be referred to the specialists at a proper time. The third thing I would say, that too much hasn't been said about, rather I would say that proved about the role of physical therapy and all that. So I won't comment on anything, but yes, physical therapy, how much it is helpful, and exactly what type of therapies are helpful, I think we should also know. So I hope that we'll be able to know a lot of things from our speaker today and all the other guests present. I wish that we could make a lot out of it. We could learn a lot of things from it, and practice it in our daily lives. So with this, I welcome our guests again, and thanks to the department for organizing this webinar. Thank you.
Thank you, Professor, for your nice and inspiring speech. So thank you. So I request our HOD, Dr. P.K. Lenka, to speak few words. Lenka sir, please.
Thank you all. Again, I welcome the guest speakers and the my director, Patra sir, and all the participants. Today, basically, it's, my network is not proper, so just I'll stop my video so that I could be able to address you. The important point, whatever has been said before, it also in general to low country like India. We had a seminar recently through online platform on orthopedic intervention. The it play a major role. It has been accepted by international Scientific Society on Scoliosis Study and Rehabilitation Treatment. If I say, what are the ingredients or what are the parameters what we follow throughout the world in conservative treatment? Most predominantly, the bracing. Bracing almost covered more than 80% of the conservative treatment. There are incidents also, exercise, physiotherapy, yoga, acupuncture, FES. They also play, there are literature, they also support that this through conservative means we can arrest or we can stop the progression of scoliotic cord. Basically, if I say what is the objective of this conservative treatment, if I say in terms of 3-4 points, to basically to stop the curve progression and to prevent or you can say treat the respiratory dysfunction, to prevent and to improve the cosmetic or aesthetic or posture. So with this objective, there are a lot of opinion in this regard. Unfortunately, most of the treatment approach vary from one region to another. Again, it depends on experience and choice of physician or the person who treat first or the child where they go and report first. Although International Scientific Society on Scoliosis, they recommend or they recommended guidelines in 2005, 2011. Our assessment also, they agreed certain parameters to be followed of how we start the conservative treatment, how we start, how we assess, what treatment, when and how the bracing, how or if when exercise, these are being discussed extensively. Similarly, International Research Society on Deformity and Scoliotic Research Society, they also target for surgery or surgical intervention. In fact, we in Calcutta also, we doctors and the orthotists, we initiated a proposal to go for RCT, random clinical trial on 500 patients in SSKM PG by the help of SRS. So what our director said, it's very true. We get the patient or mostly the reported case little bit later stage. So early diagnosis, or you can say the physician or those who clinician, they sometimes ignore, parents sometimes ignore that need to, the SRS or you can say, or ISSD, they should also incorporate certain tracks, how to easily or how to very easy way we can identify by the common man or by the mothers or parents of the children, those who first notice some kind of bent spine. We all know, we all are mostly the participant and speaker, they're expert on scoliotic, what Patra sir said. Michael is very expert and we are here to exchange our knowledge and we're here to listen them further. Although scoliosis is a three-dimensional deformity, but still, mostly the conservative treatment, mostly we ignore the 10 degree of Cobb's angle and the risk of the treatment or is the better of a treatment, we can target basically 20 to 10 to 25 degree. Still, that will be discussed very thoroughly. The one thing here I want to emphasize, there is a need of standardized research method and consciousness in all over the population. Because if you see the International Scientific Society, it is dominated by the mostly developed country and few representation from low economic country, the populated country like India. So large database where the things has been ignored or the evidence-based practice should be formulated, and mostly they what I found in the literature, they look into the published literature, but there are hospitals, there are database, there are treatment facility where we can get the data to make a very good consciousness among the guideline to do a standardized research methods, or you can say clinical practice to get the effectiveness of this conservative treatment as recognized by SOS, ROT, or SRS. So with these words, I hope the honorable speakers, they are expert in this experience of the treatment, conservative treatment. Although my profession, I am also orthotist. We typically deal with this like spinal brace, conventional brace. I hope today in this webinar we will come to know the recent advancement and particularly the different types of treatment modality throughout the world. What Michael will share among us, and we'll be happy to share our information if time permit. We'll exchange our thought through questionnaires or through one-to-one talk. Thank you, Patra sir, for giving me chance to give a keynote address. Thank you.
Thank you, Dr. Lekar, for the informative speech. Thank you. So we have with us CEO of Human Study, Mr. Chris. I request Mr. Chris to say a few words before going to the speech.
Oh, then good afternoon to India from Germany. We are very happy to be able to join this webinar and have the opportunity to exchange knowledge with the humble group that we have at your end, with the National Institute for Locomotor Disabilities and Department of Prosthetics and Orthotics, under the leadership of Dr. Equebal and his colleagues. Thank you very much in the first place for the invitation. I have prepared a couple of slides, and if you don't mind, I would go on screen sharing and give you a little bit of a tour through the idea of who is human study in the first place, and then lead into an introduction to Michael Rexing, who will take the lead in the lecture today on the aspect of scoliosis treatment. Okay. So first of all, I would extend my gratitude to the National Institute and the leadership for this invitation. We are really very pleased. But also I would like to thank the ICRC in India, who made the connection for us, because we have been working on different educational models with the ICRC in India in the past already. And as it seems, there has been some outgrowth out of these activities lately, and we are very happy and very pleased. So thank you very much to Anil and his team at this end. Well, I have never been to Calcutta. My research showed that it is a beautiful city, obviously, and eventually we will have the opportunity to come together personally, especially when this crazy times of pandemic is under control at one point of time. We really hope that we will have the opportunity to visit and to meet you. Now, to give you a little bit of an insight to Human Study, this is an organization, is a non-profit organization that was founded back in the early millennium in 2005. And it is entirely specialized on education and training in the field of physical rehabilitation sciences, with a focus on prosthetics and orthotics. And we are also, as with our educational programs, we also received the recognition and accreditation by the International Society for Prosthetics and Orthotics. But what is driving us? What was the idea in the first place? Why we have started to work with Human Study is the reality, the sad reality that there is a huge need out in the world, and there is very little answers and very limited access to quality services in prosthetics and orthotics. These figures are based on WHO standards that have been published in late 2017, where they say that at least 80% of the population in need has no access to quality services when it comes to prosthetics and orthotics. And this is all based on an even more interesting, more crazy information when we look at it, that they say between 0.5% and 1% regularly of a population are in direct need of prosthetic and orthotic services, according to WHO. For India, as you're over 1 billion, this would mean that at least 10 million people only in India have a direct need of a prosthesis or an orthosis. So now we could break this down on the number of qualified, of trained practitioners to address these needs, to provide quality services. And this number is devastating, is huge. And I'm afraid that also in India, we have a great gap, like we have it worldwide, against the needs and the available services. And this is the view we have on the world, on the prosthetic orthotic world, that drives us. This is our core motivation to deal with this problem and to create an answer and to help to make the difference. So what are the solutions? I don't think anybody has a solution out of the box. Obviously not, because it's really a long-lasting and a large problem we are facing for the people with disability around the world. But what we have been trying to develop was an innovative way of educating people. And what we learned was that there are very many practitioners, very many technicians on the job that had no access to formal education and training. So our first and foremost targets for our educational programs are actually those practitioners that are already struggling to provide services, but do not have access to education. This is why we came forward with what we call blended learning education, which is available around the world with the format we are delivering this education. It is a very flexible and user-friendly application of education, and it's extremely cost-effective because while we provide education and training, our students, our practitioners are on the job, continue to be productive, they continue to earn an income while they receive the education in parallel to the job. And this is what Human Studies stands for. So under the blended learning, we have a three-way blend that we are working with. The one is easy and well known around the world. It's the online streaming of academic information in the first place. There's a multimedia, very interactive learning environment online that we have created, where we are streaming all the academic portions of our educational programs. The second blend is the hands-on, the clinical training, which we typically organize on-site at a centralized location of our targeted regions. And the third blend, actually for us, in our 15-year experience, the most important is the junction. It's the interaction that people are constantly on the job executing P&O work on a daily basis, and they are sitting in a classroom at the same time. And the interaction between the lesson learned to transport this information directly into the daily work and the experience you make with that to bounce back into the classroom. This interaction is actually extremely powerful in the learning curve of our participants and students. So that is our three-way blend. Just a short insight on how we apply this. We start on the bottom, which is lifelong learning. That is an opportunity to specialize and to strengthen, to deepen your knowledge and your skills in a specific area of your profession. We call this specialized courses in prosthetics and orthotics. And these are short courses if you want. We have a short 5-6 weeks of academic streaming online, which is then followed by a clinical hands-on workshop, about 10 days in average. And then at last, a 3-month period where we allow the participants to follow up and really to exercise the lessons learned and to file in a number of case presentations where we assist in the making of and where we also reflect and review together with the peers. Okay? So that was for the lifelong learning, the specialized courses. The next level of education is the fundament of education, if you want. This is what ISPO calls associate prosthetist orthotist under the new standards, formerly known as ISPO category 2, and it is a 2.5-year education for practitioners on the job who have a certain amount of experience but had no access to formal education. And it's about 2,700 hours of effort to run through this program, which is ISPO category 2 accredited, and you will receive then your certificate as an associate prosthetist orthotist with this program. Okay. No? Next. Something happened. So here we go. And the top level education is actually then, and that was an outcome of our associate programs where graduates came back to us and literally asked, what is next? How can we go on the next level of education? So we literally were forced by our previous activities to build what we call upgrade program, an upgrade program that leads to a bachelor degree and which is also accredited by the ISPO under category 1 standards, which will lead not only to a bachelor degree with our partner universities, but also to an ISPO professional prosthetist orthotist acknowledgement. Okay, this is a 3-year education, a 6-semester upgrade. So the entry requirement is that you hold an associate level already, category 2 level already, and we build up on that to bring our students to a category 1 bachelor level, and it has a focus on complex and difficult treatments and all of the specific areas that we cannot work in the CAT 2 program at first. And it also has a focus on building teacher and trainer capacities. Okay, so like that, we have a whole circle of educational programs from lifelong learning up to degree level, and all of it accredited under the international standards. Okay, well, here just a few snapshots and a couple of the space on the slide was not large enough to list all the countries. I can tell you we have operated in more than 20 countries around the world on 4 continents, including India, as you know, and we are providing our training and education programs literally around the world in different contexts, multilingual. So we give our best to make it as accessible as possible. But so far, that is for human study, just for you to get an understanding who we are, what we stand for, how we operate. Now, allow me to drive this introduction towards Michael Rexing. If everybody could please mute your microphones. We have some disturbing noise in the background, please. Michael Rexing, your lecturer today, is a true expert when it comes to dynamic brace solutions, when it comes to scoliotic treatment. He has a whole career of experience with locomotor disabilities, and he works in Heidelberg, which is the epicenter of prosthetics and orthotics research and services in Germany. He currently works for a company called Adviva, which is one of the leading companies in Germany, and that has a focus on the rehabilitation of children, and also especially with pediatrics, in the field of orthotics and spinal braces, but also seating and positioning. Okay. Michael has a long career as a professional in that field. He's a member of a number of associations. He's also a board member of Human Study, and he's also the board member of the ISST, which is the International Schroth Scoliosis Therapy Association. That is, you will know when we look at the scoliosis treatment, Katharina Schroth has, based in Germany, back then has developed ideas and techniques, especially on the side of physiotherapy, to provide treatment and exercises for children with scoliosis. Okay. And Michael has been as a trainer and a lecturer around the world on the subject of spinal bracing and other dynamic orthotics. Another specialty besides spinal bracing is also the treatment of deficits by when we look at dynamic ankle foot orthosis to overcome locomotor difficulties, especially with children and other elements. Okay, so he is around the world operating with a number of universities in Asia, in Germany, and in other parts of the world. So Michael, here are a couple of your photos, Michael in action. Actually, today we are going to enjoy a webinar. A webinar is quite limited in the know-how transfer. Obviously, we can only talk about things. We can show a couple of videos and graphics and pictures. The important element of working together hands-on to really provide services together and to apply the knowledge, the applied sciences, hands-on patients, and to assess and to evaluate the outcome is another story. For that, we probably should come together at one point of time and work on different scenarios and on different subjects, but that may come at a later point. But I think the true quality of Michael here, he loves the practical part of the profession. And I think that is his main quality, is also to really work hands-on with our students and to make sure they understand, they get the skill set that they need to do a good job on their patients. So, Michael, thank you very much for being available for us for the webinar. That was all from my side. I would hope that everybody enjoys this webinar and this opportunity to come together today as much as I do. Thank you very much once again to the organizers, to the leadership of the Institute, and greetings from Germany. I give the microphone to Michael Rexing. Thank you very much.
Thank you very much, Chris. Thank you very much, dear colleagues in India, for the invitation. So I have to start with the technical things, start my presentation. I share my screen. So I hope it will work. Yeah. So is it on the screen, the presentation?
Very good.
Very good. Okay, let's start. Yeah. Thank you very much for the invitation. I was 2 times in India. It was beautiful, inspiring times in Vellore and in Bangalore, and worked together with you on other fields. Today, I'm invited to talk about conservative scoliosis treatment, one of my favorite things. Check a little bit. So yeah, greetings from Heidelberg. I like the summer in Heidelberg. Normally I do rowing. Now it goes to winter and we get snow. Here on the left side, you see our company building. We are about 220 P&Os at the moment in the pediatric care. And I'm also a member of the ISST. In Germany, we have a long tradition of inpatient scoliotic treatments with the Schroth clinics, and all the young girls go to an inpatient treatment. And I was responsible for brace development and knowledge transfer in the group who run the orthotic center for these clinics in Germany. And I was 6 years. I worked very close with the Schroth Institute in developing braces to bring the braces near to the physical therapy. This was our goal. Why? Most of the traditional braces have their base on radiographics, and we had a long time of struggle with the physical therapists also about our braces. Why? They say you do the different opposite things like us in the physical therapies. Your braces are worse, it doesn't work. And they say to the parents, throw the braces away, do physical therapy. It's nonsense what they do. And the doctors in long times in the 80s, 90s mean bracing is nonsense, do surgery. So our goal was to bring the knowledge of surgery. There's a huge knowledge in surgery about the spine, the knowledge of physical therapy, and our small part, the P&O, together to make a hands-in-hands therapy. This was our goal over 6 years, and we developed a new classification, and now we train this theory, the system overall in the world as a hand-in-hand therapy. Our agenda today is a short introduction. We are middle in. We talk about 3D deformity and latest research. That's important to go away from the two-dimensional X-ray to the real size and form of a curve. We talk about brace and physical therapy. It's very important in Europe to do it together. We talk about European bracing schools and theories. There are other ideas about treatment, not only Chenot, and they have also good results. And we talk about how to make a brace. What is the best or the economic or the best way to do it? My career starts in 1989. It was my first seminar I gave together with my father. This is, I go look to the laser pointer. This is my father, this is me, and he was very famous for brace making in Germany. He's also in P&O, and I started very early to accompany him in courses, and later when he was retired, I do the same job. So this is Mr. Chenot from France. It was a radiological doctor, and he starts thinking about brace making and was not satisfied what the P&O did in this time. This is Mr. Rigaud from Spain. This is Dr. Weiss from Sobernheim. These three guys together hold about 15 years, each year seminars, workshops in Sobernheim at the Schroth Clinic, bring all the experts together from the world and discuss what is the best style of brace, what is the effective, most effective brace, and we learn together from each other. And we can say almost all modern braces in the world, the different names, schools, came from the work of these three guys in this time in Sobernheim. Yeah, I learned from my father's CBW brace, Chenot Boston Wiesbaden brace. It was a blend of Chenot and Boston. Why? In this time, we were very unsatisfied about the outcome of brace treatment. We had the Milwaukee with very bad results. We had the Boston, and we start very hyper engaged in Boston. We see, oh, it doesn't work so good. We get problems. And in the 80s, the P&Os start to find out what are the best elements from the different styles, and we bring it together. This brace was very popular, 10 years, 15 years in Europe. And yeah, there is posterior opening with the better apply of corrective forces about the Boston style. And also we had expansion rooms for an active derotation. Yeah. Yeah, later, but the problem was the physical therapists don't want this style of braces. It was too much passive forces, too strong on the body. They want to have more sophisticated braces where the patient also do some corrective things. They learn them breathing, and we put them in rigid braces with only passive pressure, and so also the parents wants to have the Chenot braces. One big difference was the posterior opening is a problem. So while the girl can't put the brace off, And in this time, we said to the girls, you are self-responsible for your treatment. You decided to wear the brace or not, how too long. And for this, it was very important that the patient put the brace on by herself. And so we need an anterior opening. And this was 2 reasons why the Chenot brace become so, was the most favored braces in the 90s. The results at the beginning was also bad. Same bad like Boston. We have no correction in the thoracic curve. And please think about scoliotic treatment is aesthetic. It's the shoulder and the thoracic area where the visible deformation came. And when you make a brace, what has not the power to correct the cosmesis of the thorax, then you don't find or you don't match the goal of treatment of the patient and the parents. Yeah, this is Bad Sobernheim. We do in Sobernheim about 3,000 inpatient treatments a year in scoliosis. So in this time, our company built about, only for this clinic, 2,000 braces a year. So we have a long experience and could play with a large number of patients to make the braces better. This is the Schroth family. The old Schroth, you see, it was found in the 20s. Schroth therapy, physical therapy, was very famous in Germany over a long time. But there was always a fight against the traditional orthopedic view about the spine and the physical therapy view. And the fight stops at Dr. Weiss. He is a physical therapist and a surgeon, and he becomes medical director of this Schroth clinic, and he starts to bring it together to make a hands-in-hand therapy. And this is Axel Hennes on the right side. This is my colleague in the Schroth, and he's senior instructor in Schroth physical scoliotic specific therapy. And we travel normally through the world and give courses in this treatment. So have a look. Yeah, let's start with Chenot. What is different, Chenot to all the braces before? Chenot looks not in the first view to the X-ray. He starts looking to the body and prescribe the body or make parts of the body. Some parts are prominent, some parts are deep, some parts are neutral. He gives each zone on the body a number, and he prescribes how you have to rectify your cast. Where is too much, you have to reduce. Where is too less body, you have to fill in plaster. And it was a little bit confusing system out of the normal orthopedic terminology, and it was something mysterious and in this time. And but what in this time appeared was the thinking. Traditional, we think the pelvis is the basic of the spine, we think. And so we can catch the pelvis in a pelvic girdle, and then we make an upper structure and make pressure to the spine. In this time, the idea appears and becomes stronger and stronger that the pelvis is not the basic of the spine, as we learned. In scoliosis, the pelvis follows the spine. The pelvis is triggered by the spinal deformity. Today it's clear, it's totally clear, no question about. So we make pelvis girdle and build a brace up from bottom up. Anatomical pelvis, hip and lumbar, the deeper lumbar spine, lower lumbar spine is covered and there is no independence to move lumbar apex against the pelvis. So this was Chenot. He prescribes two general pattern, a 2-curve, a 3-curve, and a 4-curve pattern. It comes later. From Chenot, Dr. Weiss in Sobernheim, together with the Schroth Institute, they developed a augmented classification after this 3-curve and 4-curve pattern. They prescribe 7 different types of scoliotic curves, and depending from what in the pelvis happened, the compensatory movements of the pelvis, they prescribe 7 different type of braces, shape of braces. So this was a moment where we, in the about 2000, we changed from a radiological brace making to a pattern-specific brace making. So we first try to find out which pattern it is, and then we choose the design of a brace. This is different, yeah. Other point was, so sometimes it doesn't work now. This is the old Schroth clinic. What is Schroth? Schroth, in the physical therapy, they learn the patient to do active corrections, to make a correction of the curve by herself. That is very important. You see how here she has a thoracic curve, left hip prominence, and in the movement during breathing, she bring the pelvis to the other side, straighten the curve, try to fill the rib cage here, the weak side, with air during breath in. This is Schroth therapy. And we have to allow this in the braces. This is the goal. From this pre-work, the Rigo classification comes. It's also a typical Chenot classification, about 10 different pattern and braces. It's a blend of the Schroth and of the Lenke classification, but it's a clear view to the radiological signs in the Rigo classification. I use it till 2014, the Rigo classification. Then we go away from the strictly radiological classification on the way to a more functional classification. Right? We learn more and more about spine and the relationship between posture, spine, pelvis, and how strong posture is and how poor our ability is to do something with a brace against a posture, what the patient has trained lifelong against the gravity. So that's the reason. At the end, we developed this Sobernheim brace classification, a 5-pattern classification. We have radiological signs like CSVL, central sacral vertical line. We prescribe all the radiological signs, but we look also to the posture and very important things. And here, to make the brace making, the confusing Chenot theories easier for all the P&Os in the world to make an easier decision, which type of brace. What is the main important point, what we have to focus on in a brace? Don't play on all curves with all pads. So find out where is the focus of the treatment. Today, you have to make high impact treatments and find out 2-3 points, what most important points to treat. And for this, we use such classifications. And here, what is the most important point in such a pattern? The most important point is the thoracic curve shift body mass to the right side, to the thoracic side. And this is not possible to live with shifted body to one side. You produce during movement moments, and you can't walk. With such moments, disbalanced spine. So you have to bring body mass to the opposite direction. And what the scoliotic patient do, he shift the pelvis to the opposite to bring the body mass in balance. This is very important when you have a walking patient and make a brace. Think about walking. Yeah, and what is necessary for walking? All moments on a walking body in a horizontal plane must be zero. All rotational moments must be zero. And this is not possible when the body is not in, or the body mass is not in balance. So then we try to focus to shift the pelvis under the apex, yeah, to bring the body mass in balance and correct the curves. Yes, so free thoracic curve pattern, but here you see this is also a thoracic curve, but with a lumbar curve. Here, the lumbar curve bring the body mass out of balance. The patient shifts the pelvis to the right side. So we have first to do our work here. This is a therapeutic relevant work we have to do. When we have the solution for this, then we can work on the thoracic curve. And so it's a system you can work with clear, easy parameters. So let's go further to the general things. Yeah, it's important to know treatment is symptomatic. We don't know and we can't stop the cause for scoliosis. The aim of the treatment with brace and physical therapy is a non-invasive treatment. We want to try to avoid the fusion of a normally created mobile spine. Surgery is fusion. This is a big difference. And the goal of a conservative treatment is to avoid the fusion of a mobile spine. And we know brace treatment is highly effective. The best study in the moment is from Aulisa from Italy from 2014. Under treatment, he has only a surgery rate of 5%. This is the top study at the moment. When you compare the treatment results with the natural history, we know about 70% of the scoliosis progress during growth. In the brace study from USA from 2013, they stopped the study while in the study they see clear bracing helps, and it's not allowed to let the study go on. Why? There was a control group without braces and they are progresses. Yeah? So they stop the study and say, okay, bracing work, all the patient has to go in a brace treatment. And we know when the patient wear the brace more than 12 hours, we have a progression only of 18%. So in compared to the natural history, it's a treatment success. But there are some studies who would say 87 patients not progress. This is an old study. In the modern study, only about 50% or 14% of the patient not progressing to surgical indications. So brace treatment is highly effective. What we also know, what is basic of treatment today, is the wearing time is essential for success. From the brace study, we know under 6 hours daily wearing time, we have natural history. When they came to 13 hours, we have a good treatment success starts, and the optimum between the burden of a brace and all the negative effect, psychological weakness of muscle, is at 70.6 hours. This is a good time for a good optimum brace result. So the time of 23 hours prescription is away in Europe. Only in high critical scoliosis, or when you start with a treatment, very hard, then you give 8 weeks after weaning on, full-time rigid bracing, and then you start reducing. So there's a positive association between wearing time and success rate. That's clear. What is not so clear is when should the patient wear the brace. In USA, nighttime bracing is very common. Why wearing a brace during the day is so bad for the girl, for the social things, psychological things. But the reason is they think, during the night we make growth steering with the brace, but it's not right. It's clear what you do during the day with your spine is relevant for the growing in the night. So the growing zones are diaries of what you do, of the load of the spine, of the movement. Yeah? And during the night, the body change the morphological structure. Yeah? Depending on what happened during the day. So it's clear, it's better for outcome to wear the brace during the day than the night. Yeah. Scoliosis, as a definition, it's 10 degree lateral curvature. Under this is only posture or something else, or radiographic failure. 10 degree, we say in the SOSOT, it's the other organization, there must be also for scoliosis a rotation of the vertebra in the curve as a definition. The view changed from the frontal plane in the radiograph more and more in brace making in the last 10 years, in surgery in the last 20 years, to the sagittal view. We know the normal curvature of the spine. We have a kyphosis, we have a thoracolumbar junction. This is this area. We have 10 to 10 plus, 10 minus, but more or less straight spine. And we have in the lumbar spinal lordosis. On the right side, you see a typical scoliotic spine in the sagittal view, and you see this is a thoracic curve. This is the apex vertebra, the neutral vertebrae, and you see what happened with the apex vertebra of the thoracic spine. It has moved forwards to anterior during the development of the deformity. Normally 8 is here. It's a most posterior vertebra. During the development of the deformity, the apex vertebra move anterior, and also in the thoracolumbar junction, it starts to become a kyphosis, yeah? Opposite to the natural. Sorry. So this is an important point for you to know. Sagittal plane. This is clear. This also, we can go fast through structural, non-structural classification on onset. We know the early onset. We don't treat with braces in Europe. Normally they get casters, and then if there is a progression in the early onset, they come to an operation. Most of the curves are resolved, are non-progressive. The juvenile have a high risk. They often go to operation. Why? They affected by 2 growth spurts. What we treat, the most of them, the adolescent, and it's important or good to know it's mostly right thoracic, and the progression is related to maturity in curve size and sex. Few curves require surgery. This is what we know. This is also clear. The progression depends from the initial curve size and the age. This is the model of progression, the model of progression is we don't know the first step. Why we get a change in the three-dimensional form of the spine. This we don't know, but we have a model of the progression. If there is some change, if there is a curvature, we have asymmetrical loading. Asymmetrical loading leads to asymmetrical growth. This leads to wedging of vertebrae and discs, often forgotten the discs, and this makes the spinal curvature bigger. The nucleus pulposus on the picture on the right side go to the convex side. The pressure against the growing zones from the disc gives the information. The pressure of the disc gives the information to the growing zones for growing. You shouldn't forget it when you later come to physical therapies. The disc play a huge role in scoliosis and in therapy. This is the progression model. In surgery, they use this progression model. They make staples in the growing plates on the convex side of the curve. My surgeons say it's not so successful. Only in very mild scoliosis you can use this surgery. Risser sign is important to know where is the girl in his growth. There are curves, growing curves, depending from the Risser sign. And you have always to imagine, the first question is, when you have a girl, you ask a mother, does she have her menarche or not? Or when she had her menarche. Yeah. Why? When the first menses came of the girl, the peak growth is away. It was in the past. Yeah. So you have only a small window for treatment with a brace, while the growth slowed down after the first menarche. So for treatment, we need this point, the beginning of the puberty. And here we have good results in this area with our brace. Here we can only hold the results or make cosmetic deformations with pressure on the rib cage. But here a brace should work in this time. Yeah, this is Duval-Beaupère. You see, this is the progression, the yellow line. The progression starts with the beginning of the puberty. When the first menses appears, the main growth has reached and what is on the way down here with the first menses. So we need the time before, at the beginning of puberty. And your doctor said it in the start. Early detection. Before the puberty, we have to treat in very, very slow curves, very early. That's what we do in Europe. We start treatment under 25 degrees with braces. We start very early with physical therapy, and we try to make the bracing in this time here. Then we can reduce the cup angle very good. We have good treatment success. Later, when the girl is older and the cup angle is higher, these are poor results. It's on the here. This is not a result what justify a brace treatment. 30-degree correction is not enough for a brace treatment. Okay, what do? We have to look to the aesthetics. The girls, the parents, the society want to have better aesthetics, quality of line. Later it came back pain and such things, progression in adulthood. But when we make braces, we have to make changes in the aesthetic. And this is what our clients want. And now it starts. How to change the cosmetic. Yeah, this is a PAS, practical approach shame from the SOSORT, and you see for each age and initial CORP degree, there's a specific minimum and maximum treatment. We don't want to over-treat the patient, but we also want to have enough efficacy. So this is a shame how we treat the patients. Why we need an exact shame for the treatment for each individual patient. We can't say each patient gets a 23-hour brace. The most dangerous time is sitting in the spool for the spine and for the progression of the deformity. That is what we know. So the other dangerous point is sitting in front of electronic devices. Yeah? This picture on the left side is from 2000. There are the surgeons, the orthopedic surgeon called it Game Boy bag. Today it's a smartphone bag. The problem, the idea is when the young girl, boy sit too long in an unchanged position, in such a kyphotic position, in front of devices, the signals on the growing blades are so bad that we produce from our daily life a kyphosis here. This is a theory, the beginning kyphosis in the thoracolumbar junction as one of the problems in scoliosis. And so we look to the most dangerous times or most dangerous situations, and they're here. In this situation, you have to veer the brace. This is a dangerous situation, and please, please, please veer it in the school. Yeah. So, Lenke classification it's not a real 3D classification. It's a radiological classification, but he looks also a little bit to functional parameters. What is a primary curve? What is the compensatory curve? And yeah, this is the standard treatment, standard classification for our doctors. And here also you see in Lenke the thoracic curve in the 4 types is always the leading curve, the pathogenesis, and sometimes compensatory things happened in the lumbar spine. And for brace making, this is very important, what happened in the lumbar spine as a compensatory of the thoracic curve, why we have to change our braces about the compensatory things happened in the lumbar pelvis region. So, current principles we use. You know it, 3-point bending systems. You have always to look to your radiographic, prescribe the curve, prescribe bending systems. Clear in each brace there are bending systems, 3-point, typical orthopedic systems. In brace making, we have a second, not so typical system. We need a pair of force system for axial derotations. Pair of force means the forces work in the same directions, not in the opposite directions like a 3-point bending system. This is typically for brace making, prescribe on which levels pair of forces work. What is the problem here in the thoracic region? We want, this is ventral anterior view, we want that the apex of the thoracic curve move posterior. This is the goal of the treatment, and this is not possible to make this movement with a passive force in a brace. So now the next point came expansion rooms, that we use the expansion of the thorax to make the spine able, the apex vertebrae able to make this movement during breath in. And I show it here in this picture. The same, you see this is a Chenot brace. You see expansion rooms. This is the posterior expansion room on the weak side. Here is the rib hump. And this is the anterior expansion room on the ventral, on the anterior side, on the rib hump side. And we try in our brace, does this Chenot correction, this Chenot movement work? Yeah, and to get this derotation and this movement, we need a stop here. We have to control the sternum. And this is one point. If you don't have a counterhold here on the sternum, any pressure of the pad, any breathing goes in lordosis. So there is no derotation. The whole correction goes in a lordosis of the thoracic spine and make the real curve bigger. This was the problem, or this is a problem of all braces try to correct a thoracic curve. First of all, you make the curve bigger. Why? You add to the curve a lordotic component. Yeah, this is the flat back. Yeah, apex vertebra moves to anterior. We control that the apex vertebra move posterior during breath in. And for this, we need this stop here. This is for derotation. This is for the posterior corrective movement of the apex. So let's see. Come on. Yeah, okay. What we also use is in the center three-dimensional imaging to see the real form, the real size of the curve. In the invitation or in the beginning, he said, oh, yeah, early detection is difficult and observation is difficult about the X-ray. We use such low-dose systems to reduce the load of radiation to allow observation of a spine. But also we learned a lot from these systems. This system can prescribe the rotation of each vertebra in relation to the other, and we get torsion pattern, and we learn to different. We have curves on the AP radiograph. They look the same, but on the AP it's the same size curve, and in the three-dimensional picture it's totally different torsion pattern. And this is one point why sometimes surgery goes wrong and often bracing goes wrong. We get upper compensatory curves under bracing, while we only look to AP, look to the side bending, correct it, but we know not the real torsion of the spine. And if there is a torsion in the curve in the opposite direction, you produce under correction a higher compensatory curve. And in brace making, upper thoracic compensatory curve is the worst thing what can happen. That you make a treat the rib hump and make a shoulder hump and a shoulder curve. Well, what you see first in a girl is the shoulder area. This is the cosmetic most vulnerable area. So for this we have these systems we can prescribe. Oh, be careful about the correction of the thoracic curve, go deeper, less pressure. There is a dangerous risk of a compensatory curve. What we also do is scanning, clear. Plaster cast it's not so favored by the girls. It's it's handicapped in our country when some people came, males, and make a cast on a female, a young female in puberty. So we bring them in a scanning room. They go in the scanning room. The scanning room works full automatically. The static scanners, it lasts 10 seconds, and then the patient is in the scan. Yeah, but we don't use this scan for the modeling, for the construction process. We only use the scan to record the outer form of the body and the individual posture of the patient. This is why we scan. Yeah. Other point is the compliance. What we know, it's also, you said it in the beginning, there's a problem of compliance and co-working of the doctors, technicians, and also the role what physiotherapy plays. The main studies on the last decade was a brace, and the brace is from the United States, EZICO from Europe, and the EZICO study has much better results. And one of the point they found out in the compare of these studies, that the girls in Europe wear the brace longer, much longer than in the United States. And the authors of the study, Weinstein, the famous Weinstein, they asked why our girls in the USA don't like their braces. And they found out it's not the type of brace. Yeah, it's they don't trust the therapy. Why? Doctors want surgery, technicians want brace, and physical therapists want physical therapy, and the patient don't trust any one of them. And so they are not compliant to the brace therapy. And this is totally different in Europe. We have a high status of physical therapy and also a high status of bracing and a low status of surgery. And that's the reason why we have better results in conservative treatment. It's a team working and co-working, and the patient trusts us. Yeah. Other point is we go away from try to treat all curves we see on the X-ray. We concentrate on the therapeutic relevant curve or on the major curve. Have design our braces to focus on the major curve so that we had better outcomes in the treatment. So this is also a way many brace schools follow. Go away from the full brace with pads for each curve, concentrate what is a really bad curve, the relevant curve, and then go full power in this curve with the risk of high compensatory curves. That's at the moment the game, how much, and the discussion. Yeah, this is the classification talked about, we use. What we also do is an interdisciplinary approach. For us, we think it's necessary. I have a noise about the open mic. Someone has a mic open. Yeah, thank you. So we say it's necessary to make physical therapy before the patient gets the brace. He needs a preparation for the brace. The patient has to learn to make the corrective movements in the brace. If not, if the patient has no idea about his scoliotic posture, the corrective posture, the movements he has to make in the brace, the patient stay in the scoliotic posture, in the brace, and then the body work against the brace. So in the end of the idea, in a holistic way, we train with our passive force braces the scoliotic posture that the patient work against. So for us, it's necessary to learn the new posture, the corrective posture, then make a brace as an exercise tool, also as an outer reference frame for the corrective posture together with passive forces. Yes. So this interdisciplinary approach means also that what the patient learn in the physical therapy, this is a lumbar pattern. Normally the scoliosis is opposite. The patient has learned it, and we build in the same corrective posture in our braces and give clear inputs with our brace, the same inputs the therapist give or the patient give to correct his faulty posture. Yeah? Clear signals for correcting, shifting the pelvis. That's also important. The brace must give clear signals to change the posture. Compliance, we know, veering time compliance, it's close together. Compliance is also in our girls, cut out the braces much as possible. We get a stability problem with polyethylene and polypropylene, especially in polypropylene. When we use it and make such cutouts, it breaks very fast. Polyethylene goes a little bit better, but also becomes weak and lose corrections. So we now work with such materials. These are 2 layers of polyethylene with carbon fiber inside in a traditional way of working we do. But we try to have more stability in the upper parts of the brace to have a good correction here in the thoracic area, and allow more outcuttings. 3D printing, there's a lot of marketing of 3D braces. We do also try to do it, but you see our learning curve, the things break. Yeah, and we can't, all our experience in brace making is about polyethylene material, what stores corrective forces we give in the plastic, in the plaster model. The polyethylene stores these corrective forces we give in our mold. This is not possible in printed braces. They don't store corrective forces. They are passive braces in a fixed form, and we can't use our Chenot and Boston cast, our style, to make the cast for such braces. So we are totally at the beginning. It's good marketing, but it doesn't work for idiopathic scoliosis. Yeah. Functional, rigid. 2 principles. The brace must be functional, not dynamic, functional. That means functional means the patient is able to go in a corrective position and can walk and sit with the brace with the normal function, much as normal function of the spine. But the brace must be rigid as possible to apply exact forces for a good correction. This is what we have as general rules. Yeah. Um, 3D deformity. Unfortunately, we get X-rays for scoliosis treatment. Unfortunately, why? 1882, Adams prescribed scoliosis as rotation plus lordosis and lateral flexion. So, and prescribed scoliosis as a rotational deformity. He hadn't X-rays. He opened the bodies of the patients when they died and prescribed the scoliosis 3-dimensional, how he see it with his eyes. And then X-ray appears, and all the knowledge of the three-dimensional nature of the spine get lost. And he prescribed wedging of the disc and a little bit wedging of the vertebrae in the apex. Very important. Here, this is a curve, but here the pathology is sitting. And this underlines the important rule of physical therapy. Why? A lot of curve is in the disc. That's very important to know. This was Adams in this time. Also, Adams starts to prescribe scoliotic pattern. Yeah? And he finds 3 general scoliotic pattern. And your eyes open wide when you see the most forward doctors in treatment today have 3 curved pattern braces. So 3 different braces. So now we are on this stage 140 years ago. We see, okay, we have 3 pattern and we have to intervene in this pattern and come back to the roots. What he also prescribed is that the kyphosis here in the lumbar area, the 3 upper lumbar vertebrae together with the 12 dorsal presents a kyphosis. This is what we treat today. On the first way, we treat the sagittal plane and restore here the normal form of the spine. After long years of error here. One you see here in this area, Boston, Milwaukee, we apply pressure, abdominal pressure, to the lumbar spine. Here, we make the kyphosis bigger, the pathology bigger, and we had so poor results with the Milwaukee brace, and I show you pictures of Milwaukee girls. Everybody knows such pictures when he did Milwaukee braces, and you see here we make more kyphosis in the thoracolumbar junction and more lordosis in the thoracic spine under the treatment. Why? This brace has a fully wrong theory about the spine and don't look to the sagittal plane. Also the Boston, at the beginning it looks better than the Milwaukee. The story of Boston is the Milwaukee was not ready in the clinic, and they take the pelvis girdle of a Milwaukee brace and put it on a girl, and it works also wonder. And so the girls like at the beginning the short braces. In Boston style, you see the abdominal pressure from the Milwaukee also here. And the big mistake for you as a measure in this idea is the idea of derotation, the lumbar spine against the pelvis. This was a wrong mistake. Today we know the lumbar spine is coupled with the pelvis, with the hips, and you can only move it normally as a block. When you try to make such an idea a symmetric pelvis girdle in a Boston module and make a derotation pad, the brace starts shifting. Well, nothing happens. In the curve, the brace shift on the body of the patient. The pads shift to the concavities, and you make the scoliosis, especially the thoracic curves, bigger. We had it so often in this time, and we are very unsatisfied. Yeah. And also Dixon described Scheuermann and scoliosis at the extremes of a spectrum, of scoliotic deformity in the lateral view, and you can beautifully treat a Scheuermann with a Boston brace. In a scoliosis, you make the flat back bigger. So don't forget it. Don't use the abdominal pressure. We know from the Boston we need minimum 50%. In Chenot we say 30%. Why? We have more active correction in the Chenot. So we don't want to have so much initial curvature at the beginning. In Boston, it's passive correction, so you need more when you only work passive with the spine. It's only for lumbar curves, and it increases the thoracic hypokyphosis. Yeah, this is from the original authors, and it's a mistake. Our Boston was a mistake. Yeah, sorry to the patients, but we make the thoracic scoliosis bigger. And what we did in Europe, we make superstructures on the Boston idea, make it longer. These are modern, on the right side, modern Boston braces with this superstructure. Yeah, you see there is no abdominal pressure. They have asymmetric pelvis. Also, it looks more like a Chenot. They have also expansion rooms in the Boston now. And the only difference maybe is ventral or dorsal opening, and the Boston is always fixed on the radiological classification. There are no functional ideas in the brace, so there is no brace pattern-specific bracing in Boston. Yeah, this was the famous theory in the last 10 years, the RASO, relative anterior spinal overgrowth. The idea was that the anterior part of the spine grow faster than the posterior part. And this leads to an lordosis and to a curvature of the spine. We say it's not the primary problem, the growing of the different parts of the spine. It's a secondary phenomenon at the moment. And the other argument, the asymmetry is between the anterior part and the posterior part is located predominantly in the disc, yeah, and in the apex, not in the junctional zones, and the other parts of the curve in the spines are normal. So, the RASO theory, I mean, it is dead. Yeah. Now this theory from Schlösser is the current theory. It's called Castelline, Covenhofer, Schlösser. This is the theory of scoliosis as a disease of the mankind. No other mammals have scoliosis, yeah? And only the humans and only the apes have no scoliosis. Yeah? And you see the difference between an ape and a human. This is a sagittal form of the spine. In an ape, all the end plates are tilted to anterior, so all the shear forces go to anterior, like a four-leg mammal, like a cow. Everything goes to ventral, to the body, and in this direction the spine is stable. The only animal who has an unstable spine is the human, yeah, caused by his upright position. This is the current theory of etiopathogenesis of an idiopathic scoliosis. Why? You have seen this is the spine. This is the when the spine is, or the vertebra is anterior tilt, the shear forces go to ventral. Against this ventral directed shear forces, we have good structures on the posterior side who fix it and make the spine close. Lordosis makes close. Think about lordosis, stabilize the spine. Yeah? And kyphosis, posterior inclined vertebrae make the spine unstable and lead to a rotational deformity. This is today the theory, the biomechanical theory of the appearance of spinal deformities, especially neuromuscular scoliosis, also in idiopathic scoliosis. They make studies about control groups. There are the normal inclination of the vertebrae in a thoracic scoliosis. In the apex region, we have a higher inclination. Before the scoliosis comes, very early, we have changes in the sagittal parameters, with a higher inclination. When we have a higher inclination in the thoracic region, we get a thoracic scoliosis. If we have a higher inclination, posterior inclination in the lumbar area, we get a lumbar-dominated scoliosis. This is the current theory after I built my braces over all type of scoliosis, neuromuscular, idiopathic. You see a SMR type, spinal muscle atrophy. The patient is not able to sit independently with his muscle force. Before he do something with his head, with his hands, he has to stabilize the spine. He stabilize the spine with his bones and ligaments and go in a typical rotational deformity to make the spine stable. So that's important for you to know. Any change in the pelvis leads to a change in the spine over the pelvis in the sagittal plane. The more we have posterior directed shear forces, the more the spine becomes unstable in sense of rotation, and this could lead to a scoliosis. That's the reason why we don't apply pressure on the pelvis, anterior pressure on the braces, and we don't apply deep pressure on the glutes. We don't want to have, especially in sitting, a posterior tilted pelvis. Flat back with L1 kyphosis, that's the sagittal description of a scoliosis we see today. We have to apply forces to shift the lumbar area anterior, the thoracic area posterior, to bring the spine in a balance. Sitting is a big problem. Most of the children sit. Most of the time they sit. In sitting, the pelvis tilts posterior, that's normal. And we pronounce the kyphosis during sitting. This kyphosis and the posterior pelvis tilts lead to a reactional lordosis in the scoliotic curve. So in this scoliotic curve. So that's the reason why today all the braces are cut here. Not goes deep on the glutes, and we don't apply abdominal pressure. Don't promote the progression of the deformity in sitting. The other point is bring this by our doctors look that the girls in the brace are in a balance, in a global balance, frontal and sagittal. They have to bring the center of mass near the hip joint. It's not good prognostic when the center of mass is in front of the hip joint. When you have such a static, then you have to bring with active forces parts of the body backwards, and you make the thoracic lordosis higher. This is mean with global balance. We look with laser posture from prosthetics to the global balance during fitting of the brace. Important to know, there is a change in the physiological rotation of the vertebrae, especially in the thoracic area. There is a pre-existing vertebral rotation in humans. It changed during growth from left to right. That's one of the reasons why they think why early onset scoliosis, juvenile scoliosis sometimes have or often have a left thoracic curve, or early neuromuscular scoliosis have a left curve, and later in the it changed to the right side. The normal rotation, it's called left-right axial vertebral rotation, conversion of the rotation. And This is in this theory about an unstable spine and a pre-existing rotation, why we get deformities. So, yeah, conclusion about brace making in Chenot. When the patient is blind, we expect a final correction about 7-degree COP. That's what we find out in all the studies as a yeah. So the middle line, low compliance, low initial corrections, bad outcome. In Chenot, we want to have a minimum initial in-brace correction more than 30%, and we start the brace treatment under 20-degree. Here, an overview about studies, and you see in so you see in the studies. So, can I go further? Yeah. Okay. You see in the studies under brace treatment in Chenot braces, we have round about 85% of the patient are not going to a surgical intervention. So that's good. Yeah, there are some compares between bracing schools. We have the compares studies from Canada, USA, Europe about Boston brace and Chenot brace. What is the more effective brace? Boston brace can't do anything on the rotation on the apical thoracic vertebra. We know the studies. The Boston can only correct in the coronal plane. Chenot braces are intended to derotate, and they are able to do it sometimes and are able to provide a 3D correction of the spine. Yeah, there are some studies, there is an improvement of the angle of the rotation angle compared from Chenot to Boston. It's clear in a Chenot brace we have active elements, functional elements of the patient. He can do the correction with his breathing and in change of his scoliotic posture and habit. Yeah, never apical vertebra derotate. The best results we have is in the ultra-rigid braces. So this is the South European school, Italy, Spain, France. They make totally rigid cast, 24 hours treatment, and press the girls in forms and let them grow only up, not to the side, and they have very good results. This is also a school. Another school is two-step bracing. They start with a correction cast, with a bending cast over 8 weeks or 12 weeks, and make a highly high intervention in the spine, special in the disc and in the soft tissue. Cast is high effective when you want to change something in disc and in soft tissue. And then after the curve, the soft tissue curve, not the bony structures, the soft tissue curve is corrected, then they gave a brace for the treatment to hold the casting results. This is a very good method. I do it together with the doctors when we have very early onset scoliosis, juvenile scoliosis. We start with casting in the clinic, and later when the cast has the treatment result, we give a brace to fix the casting results. This is also a way with good results. Two-step. Lyon brace from France, they have also very good results. less surgery, less than 2% go in surgery. Very good results, very rigid braces, yeah. How do you like it? In Germany, we can't do this style. Our physical therapists don't accept. The problem of such a rigid bracing is the muscles. Yeah, the patient lose all her muscles. You can press the body in a form, in a good cosmetic, and then you get the problem in the weaning off of the brace. Yeah, you need a long period, 1-2 years, to bring the girls out of the brace. Why? When you make the brace off, the spine collapse. Yeah? This is the dark side of this treatment. Very good cosmetic results, yeah, but a much longer period of treatment in the weaning off. Why? The patient has no muscles anymore. And so this is a trade-off. We make active braces with a lot of movements, active corrections, but our girls, when they grow out, when the growing is over, they make a very fast weaning off, about 3 months, maximum 6 months, 3 months only in the night, during the day, no brace. Why? They have a better physical condition then. Yeah. In the beginning, the problem of the X-ray, the X-ray prescribe something what is not interesting for the patients. Normally, the deformity, the rib hump is interesting, and we look to less invasive, cheaper things to measure the progression or the correction. And one is from England, the Deformity Asymmetry Index. Lenki also works on a Lenki Deformity Index. You make 3-dimensional pictures with a camera, here in this with an easy time-of-flight camera, Xbox camera with a special software, make 3-dimensional pictures of the body in a regular shape, and the software show you the deformity index, yeah, how asymmetric the body is as a number. That's very helpful. The girls like these pictures. They easily understand that she has a problem here, a deformity, yeah, and she wants us that we make a symmetric spine looking, yeah, and this is what we follow. We do this. It's a very cheap system, and the Staffordshire University gives the software for no cost, and you only need an Xbox camera and a laptop to make these pictures. Yeah, a little bit about show therapy. Show therapy, physical therapy here in Europe, very important. It has always three parts: outpatient therapy at home and in the office of a physical therapy, intensive inpatient rehab program in a clinic, and sometimes camps, boot camps, short rehabilitation. Girls like in holiday go in a rehabilitation camp, and it's with yoga and anything interesting for the girls, and make high impact physical therapy. This is the basics. Why is physical therapy so important? This is what we orthopedics see, a thoracic curve. For the girl, it means body mass is shifted to the right side, and she has to compensate it. Yeah? Compensate, build a curve here or build a curve here. She make a pelvic compensation, so the curve leads in the pelvis. The pelvis becomes an obliquity, so this curve is not fully compensated till the spine reaches the pelvis. And when the curve is not fully compensated, the curve goes in the pelvis. And now the problem starts with bracing. It's a problem, you understand, when you have a pelvis obliquity, make a good brace here. What shall we do? Physical therapist can bring the patient, bring the pelvis in this direction, yeah, to compensate the curve. And this is a huge change in the behavior, in the posture of the scoliotic body, of the brain. And for this, we need a physical therapy. A brace can't do this extreme change in posture. We can only hold later the new posture or give an input, an idea, but the patient has to learn it to correct by herself. Also, when you have a lumbar curve, yeah, you have also the lumbar curve is not fully compensated till it reaches the pelvis. Yeah, we, as a sign, always we use L4. When the L4 is tilted, it's clear the pelvis must be tilted to the same side. L3, L4, L5 is straight, fixed with the pelvis, with ligaments, muscles. It's not possible. Yeah. So L4 is a big sign for you how the plates stay. Is it compensated or not? And for your brace, it's also a big point how to which side L4 is tilted. Here the lumbar curve is not fully compensated, so the pelvis go in the opposite direction. I need a physical therapist to correct this. Flat back also, with breathing, you can change the idea about breathing, the awareness. The awareness for the body is so important for scoliotic patients. The more the girls are covered with clothes from the society, hidden from the society, the worse the scoliosis go. Yeah, when I go to other countries, like I was in Iran, Tehran, it was horrible which curves I see. I never seen such curves in Europe. Why? In Europe, the girls look in the mirror, other girls see it, they go in baths on the beach, and people see there is something wrong. And the intervention comes very early. Yeah? And they have no awareness about the posture, the symmetry, no awareness about her body. That's the problem. And I can't give with a brace awareness of my body. I can only apply passive pressure and give an idea where the physical therapy also give awareness or push or pressure. So physical therapy is absolutely necessary. Yeah, why? What is the normal pathological pathway of a thoracic curve? Yeah, it starts with a normal, then in the progression, the apex vertebra move anterior, we get a flat back. Later, we get a side bending, a trunk shift, and we became a rotation with a rib hump, weak side. This is at the end. Yeah, and now think about make a brace to bring this apex here back to this position. It's really difficult to apply passive forces to make this. I only can make the lateral bending, can make shift to here. And for this, we need physical therapy to learn active with breathing to bring the apex vertebra back to its natural position. Also in the lumbar spine, the pathology or the pathway is different. Yeah? From the normal lordosis, yeah? From the normal lordosis, we have normally in the lumbar spine a shift. Why? The lumbar curve is normally a compensatory of the weight shift of the thoracic curve, and there is bring body mass to the other side, make an opposite moments with your body. So the pathology is different in the lumbar spine. Here the patient starts compensatory shift mass to the left side, and then later a rotation came and the lumbar prominence appear, or bring it back here. How to make it with a brace? It's very difficult. You need an active movement. In short, they say it's not possible to bring the apex back to here. We do in our braces, when we have this situation, we bring the pelvis to the apex. We shift the pelvis under the lumbar apex vertebra. This is possible in a brace with a huge shift in the brace. So, yeah, why physical therapy is so important? It's about the concave compression. It's about the collapse of the spine, also in the disc and in the soft tissues. I want to go to the next picture. So, yeah, what happened? Yeah, the nucleus pulposus shifted to the convex side. It's a theory that it's not possible to make a symmetrical swelling during the night in the disc. For a symmetrical swelling, what very important is for the correction of a lumbar curvature, you have to make the discs symmetric. You need exercises to suck the liquid in the disc and bring the nucleus pulposus back in the center. For this, you need physical therapy to do it. While it's movement, it's motion, it's special exercises, and not only lying in the bed and wait that your discs swell symmetric during the night. This doesn't happen. This is a theory. Yeah. About short classification, the idea is to make blocks of the body, functional blocks, which can make shift and torsion again. In the block, shifting or torsion is not possible, so we have functional blocks and shoulder, thoracic, lumbar, hip, pelvis block. After this, we look how the blocks are shifted, in which way they are shifted and rotated. And we do later the same when we make braces with cast. We cut the cast in the neutral between the blocks and we shift the negative blocks of our negative cast and bring it in a good position, and then we fill it with plaster. This is the normal way you make Chenot bracing with casting. What you also have when weight is shifted, you can measure it. Where is the weight under the leg? On which side is the stance leg of the patient? What is his favorite posture? And so we look also to this, on which side the patient stand. Is it on the scoliotic side or is it symmetric? Yeah, normally the weight is on the scoliotic side, on this trunk overhang. Yeah, this is a classification. Always think about you have a problem in the pelvis. When you have a lumbar not compensated lumbar curve, you have abduction, adduction in the hips. You can also test it. You see a difference. Have a look in throat. We decided two main group of patterns: T pattern, thoracal pattern. That means the thoracic curve is the curve who brings the body out of balance. And we have predominantly, or we have first to treat this T curve. Why? The body is not in balance, the weight is on the right side, on the thoracic side. And these are the two main thoracic pattern, a lumbar and hip block in one, or it's a little bit a lumbar curve. It's a lanky one A, this is a lanky one B, at the end. We have this also in the lumbar. When we say we have a lumbar curve, the shift of the lumbar block, no, come on, to the lumbar side brings the body out of balance. Yeah, then the weight is on the lumbar side, yeah, and we don't focus on the thoracic curve first. Yeah, the lumbar curve brings the body out of balance, and first we shift the pelvis under the lumbar apex to bring this here in balance, and then we look to the thoracic curve. Is there something to do to add with pads, make the pecs stronger or so? But the first view when we have a lumbar pattern is that the pelvis shift works, that it comes in the brace. Now we start not in fitting with the thoracic curve. So that's the difference between a radiological way in brace making when you have a functional way, a physiological way. This is the other thoracic pattern with a more neutral pelvis. Yeah, so yeah. And then we get a description in short. On the first point, there's always the relevant curve. This is a thoracic pattern, the thoracic right, lumbar left. This is a thoracic right, hip left. This is a left lumbar with hip and thoracic right. This is a left lumbar with a thoracic right. So these are a prescription in a physiological way to prescribe a scoliotic pattern. And the first, we try to bring them out of this scoliotic posture. Elements, there are a lot of elements in the therapy: clear, tension, stretching, pelvis correction, corrective breathing. These are the elements. Some I show you easy. These are easy exercises for the girls at home. Yeah, how to sit, how to stabilize in a daily work, how to learn breath in an expansion room. We put sponges in the breathing room and they press the sponge or press your hand here in the expansion room. Yeah, to learn how to move. This is part of physical therapy. Yeah, typical exercises. Why we do physical therapy and brace together? We want to improve the compliance and make the brace wearing hours higher and have a motivation and commitment of the patient with the therapy. That's very important. At the end, they have better results. And we want to decrease the rebound effect in the weaning phase. This is a problem. Yeah? And so if the patient has a good physical therapy under brace treatment, he has less rebound effect, we hope. Yeah, this we talk about two-step bracing, a progressive action with a cast, and that, with a good work in the soft tissues, and later the brace to hold it. These are the ultra-rigid brace from Italy. Symmetric braces, so they make a symmetric form of the body with a totally rigid brace from polycarbonate, totally close. There is no space, and the only way for the patient is to go upwards in this brace. Everything, the brace has a sloped form. Yeah, so when they breathe in, the only way is to expand up. It's a typically Italy brace with good cosmetic results. It's clear when you're doing growing of the body, given outer form. We know it from Japan, from bonsai, from anything. Form follows function. When there is no function in the body, when you're given outer form, the body gets the form you gave in, with the cost of long time in weaning off. It works. different styles. Symmetric. We make the patient during grow, we will let him grow in a symmetric form. The idea is not that they don't prescribe curves, they prescribe sloped areas and give some pushes to correct the sloped areas. You see the push, everything make the spine longer and push it upwards. This is their theory. Also in French, it's also an ultra-rigid brace, but they make an asymmetrical rigid brace. The idea is that the scoliotic spine is a twisted column, and they untwisted the column in the opposite direction, and it also works. How they make it, they also add expansion rooms. They learned a little bit from Chenot, the French school. These are the other schools we have. All were successful, and the problem is the compliance with this form of treatment. If there is no compliance, each brace is bad. Compliance means also less appointments at the doctor and at the P&O department. So you need, the more you make changes on the brace, the often the appointments came. For this, they had the idea in Canada to make brace simulation. So they make a model, a numeric simulation of a brace, and make a scan of the patient, underlie the X-ray, and then they make a simulation how they have to shift the pads and apply the pressure, and then the model change the X-ray, and when they are happy with this simulation, then they carve from this simulation a model for a brace. They reduce with this technique how much the patient comes for changes in the office. That's clear, and they better the Boston. This is a Boston brace. The Boston results with this technique, from the poor results to a little bit better results. So why in the simulation you see general failures of your brace, wrong trochanter extension, wrong position of the pads. And this reduces the burden to the patient and higher the compliance. But it's clear in studies, CAD-CAM techniques does not have an impact of brace effectiveness. CAD-CAM is only a tool to standardize the rectification, to use pattern classification, and to make the brace making cheaper. But it has no effect that this is a better brace with a CAD-CAM. But in the long run, when you have a good library, then you reduce the technician's errors. In each cast you do, you have errors. I never made a cast who was perfect from a patient. There are so many factors influencing, and so things happened. And in bench alignment, when you cut your negative, then you make the real correction and see all your mistakes, and then you start modeling. In modeling, you make mistakes. And the problem is when you, during fitting, be aware, oh, I made a mistake. When you made it by your hands, you don't make a new brace. Normally, you have not the time to do the whole process. The patient, casting again, what the hell? And you try to fix this brace with a failure, and hope she grow fast that you can make early a new brace. And when you have CAD-CAM systems, you make a new brace. Oh, totally wrong, my idea. Yeah, come on. Yeah, a new brace. It's very fast and cheap. In this way, it's cheap. Make a brace again by your hands. That's horrible. Our way is casting frames is a way. These are an outer cage where the patient is in, and then you have pads, you adjust the pad, you have your idea about the scoliotic pattern, you use it also for Chanot braces, you have the Chanot theory, you make your correction part, you can test out how much you can correct the spine passive. That's very helpful, such a system. Main problem in this system is these are external forces, and the brace is on the body. So each pressure you apply on the body, apply pressure on the brace. And it's Newton, the third law. And when you try to correct the spine and you have mistakes there, then the brace migrate on the body. That's a problem in this system. It's very good to test out what is the maximum applicable passive forces. Yeah, then you scan in this cage with the pad, the patient. Then you in rectifying, you make the pads out and you have a ready model. This is also a way, but you must be also a very good brace maker to use this tool. Without the theory, it makes no sense. Other way is the French way. They make free scans. They make the correction of the patient in free scans. They start with an self-active auto elongation of the spine. Then they make a second capture with the lumbar shift. You see, the lumbar shift is very important. And make a physiological lordosis in the lumbar spine. Then they make a picture. No, come on. It's a little bit explain. The problem here is when we have a lumbar curve, here is a compression, a shortening, and the lumbar shift is very important to open this side. This is necessary for curve correction. So lumbar shift, come on. So then they make the thoracic shift, correct the thoracic curve, make a physiological kyphosis. Then they overlay these three shapes to a form, make it smooth, make a rigid brace, and now they have an untwisted spine with all the three correction movements you need to correct the spine and fix the patient for 1 year and 24 hours. Yeah, what I prefer, it's made by measurement, or what we do in our company, and in the most of the scoliotic companies in Germany, we made by measurements. We have standardized picture about the scoliotic posture, about where are the curves in the forward bending, where are the rigid areas, where are the flexible areas, how is the posture. We record in pictures, we make forward bending to record rotational parts. This is standardized. We make exact measurements of all parameters of the body. We look to the CSVL, also to radiological parameters. Here we have a lumbar pattern. The trunk is shifted to the left side. Here is C7. You see it clear. And we make a decision which type of brace we made. Yeah, after examination, after looking to the posture, we say, okay, this is a lumbar pattern with a hip prominence to the right side. So I make an S3 pattern brace. Yeah, and my main therapeutic point is to shift the pelvis under the apex to make a huge pelvis shift. So this pelvis shift, yeah, this is the pattern. I decided this is this pattern. I make this brace. When I have made the decision which brace I make, I go to my measurement sheet. Here's not all the corrective forces. This is the pelvis shift. Here's the hold. And here is a little bit correction of the thoracic curve. Why don't make no sense to make pressure here too much? Why the apex of the thoracic curve is in the center? It makes no sense to give too much power. So, yeah, I measure the maximum possible shift I can make with the pelvis under the apex. And this is necessary to get in this lumbar pattern a correction. And I measure this, and this is a very critical measurement. Trochanter to a plumb line from the apex. I test it out, and we make a cast. Before we close it, we open it anterior for the later overlapping. We make on the back side, draw our X-ray with the apex. This is also normal. Then we make bench alignment. We have a decision, which pattern, which type of brace. Now you see I made the pelvis shift against the lumbar apex. Yeah. And this is the measurement I made with the body calypso during examination. And then here we make the intervention in the sagittal profile, more lordosis, more kyphosis. This is bench alignment, is part of the Chenot bracing. Here you see such physiological, such correction parameters we need. This is our measurement sheet we work with. And now at the end, I show you in real time how we made brace. We have the measurement sheet. This is here. So I need 1 hour for examination, make pictures, make functional parameters, make a decision, and then put per hand all my measurements here in the digital measurement sheets. And then the computer works. I take this model from a library. This is a very good model I made 1 year ago. This is my standard model for an S3 brace. Now I make the length, the width, bring it to the mass of the body of the patient. It's very fast. It's always work to the measurement sheet where I measured. I bring it to my library model. And so now I make the intervention in the sagittal plane. I restore the lordosis. I give a little bit more kyphosis. I bring the 8 vertebra posterior. Now I make the shifting. She can make a little bit more pelvis shift, but thoracic, it's too much. To my measurement, I need less. Here I can give more. I need a little bit more expansion room. That's all. Yeah? And now it's rendering. The model is ready, and go to the carving machine. That's how we work. It reduces failure. Yeah, I have a very good model. It's my current theory to treat this scoliotic pattern. If I see after 50 it doesn't work, I change on my basic model some things, yeah, and then I check it out the next 50. And this is a good learning curve. Yeah, I need a standardized model and have to learn with this model. My experience is when I make it by hand, by cast, yeah, it's important to learn to correct the spine, to make bench alignment, make cast, to understand everything. But later to learn really, you need such tools like library models and only change one parameter. Look what happened in the next. Yeah, that's all. Thank you very much. And now I'm not clear. Are we open for Q&As? I'm here.
Thank you so much, Michael. If you would like to look at the chat, I invited the participants to post a couple of questions in written to the chat room.
Yes, that's very good.
And one question was posted there so far in the chat here. That is, the question is, when should you go for surgery or consider surgery as the option? Is this, is this depending on a higher COP angle, or, what would be your opinion, your position, looking at the deformity of the spine, whether this is for conservative treatment or it goes straight to an operation?
One parameter is the real size of the curve. The real size of the curve is how much the thoracic curve is lordotic. Yeah? The bigger the real curve is. The real curve, scoliotic curve, is the side bending plus the lordotic component. Yeah? And we know we have bad curves, they go to surgery, but we see it only in the three-dimensional X-ray, and we have good curves. We have curves with less lordosis. Yeah? We can treat with a brace. The more lordosis is in the curve, in the thoracic curve, the more problems we have in treatment with a brace. And there are some parameters about what is a bad curve, what is a not so bad curve, and what is a good curve. It depends from the rotation and the lordosis. But this the doctors do. Yeah. But I have a feeling for a bad curve. When I see a flat back in a young girl, a real flat back, I know this would be really, really a hard case, and normally they go to an operation. And I suggest early to go back to the doctor and say, oh, I'm at the end with my brace. So the lordosis component is one component. The other component is the patient don't want to wear braces. Yeah? It makes no sense, and the patient is not compliant. And we know this curve going progression. We send the patient earlier to surgery. And yeah, we have clear rules. It depends from the curve type. So we know C pattern or not compensated curves, with a huge pelvis countershift to the opposite direction, have a bad prognosis later in adult. But the progression, the later progression is higher, the more the scoliosis is not in balance. Yeah. So in this case, it's also it's better to say, go to a surgery. Yeah. Why after the growing is finished? Why? This is not a stable curve. She has a progression in elderly. So that's the reason when go to surgery. Sometimes in neurological cases, this is also better to do a surgery. Why? When I can't apply active forces and the patient can't work together with physical therapy and active movements, has no idea about self-correction. Yeah? The results of the brace normally poor. Yeah? And it's better early to say, okay, think about operation. Yeah? So these are the parameters, I think. Yeah? I see when I fit a brace, and you see, is the patient able to do correction or not? Yeah. And is not able to do things by herself, you get worse results normally. Okay.
Thank you very much.
There are more questions. If we have time, maybe we answer one more question. I don't know, for the organizers, are you okay with that?
Yeah, Michael should have some cup of tea or water. He talked about extensively, reviewed most of the orthosis in completely. We are so excited and satisfied. Your talk. I don't have any word to express, but I found everything covered in a 2-hour lecture. The audience, the participants are very fortunate, very lucky to have your lecture. Means I have 3-4 more questions, but I'll not put this question because I hope you need tea or coffee at least for 5 minutes rest. If audience or if organizer Patra sir or if permit, we can go for a break. Otherwise, I think we should conclude to give a rest at least. But other says, where is Patra sir? Mr. Air Patra?
Yes, yes, I'm hearing.
Okay.
I'm here.
So I think if sir permit or if the speaker allow, I have question. Otherwise, we'll conclude the session.
Yeah.
I think there is no question from the audience, so we can go for vote of thanks because
I think Patra sir, there are 3 questions.
3 questions.
Yeah.
Oh, okay. Then
So
another question: when the addition of will be considered important? Will be considered important? Okay.
Yeah, addition of pelvic girdle. Yeah, sometimes when I have high curves, when the apex is higher, then normally you have a symmetric pelvis, and then it's allowed to make the pelvis girdle on the side on the side area deeper. The deeper the pelvis girdle goes, clearly, the more correction you have in the upper structures, or you can better control side bending or higher curves. So when I have a high thoracic curve, I make a more fixed pelvis girdle. This is one reason. Also, when I see during examination, the patient has no understanding of his body, that he will never be able to work with me, he falls in his posture, then sometimes I decided to fix the pelvis with a pelvis girdle, with a deep brace, to control the curves while the patient is not able to do it. Also, when I have neurological cases, I go deeper. But this is the other question from the auditorium. We have to look in the sagittal plane. Deeper means not we make abdominal pressure and gluteal pressure. Yeah, when we go deeper, we be careful about the sagittal plane and try to have in the sagittal plane the physiological position of the pelvis. But for frontal plane corrections, sometimes you have girls, they are very kiddie and playing and falling to each side and so on. You get crazy, yeah, with an open pelvis, yeah. Then I better close it, yeah. And so in younger girls, under 10, often I close 10, 11 years, I close the pelvis and go in a more passive, passive braces and wait till her brain and her self responsible and her awareness is higher. The awareness and self responsibility for the scoliosis come with the puberty. And when you have girls before the puberty, it's sometimes better to make a close brace, a more passive brace. Yeah, why a girl before the puberty do what the mother said, and we apply more pressure. Yeah, in the puberty we give active tasks for the patients. This is a different. And biomechanical high curves need a good stable basis to correct.
you, Michael. Maybe a last question to pick. The question what came here was for the leg discrepancy.
I read it. Yeah.
How do you see leg discrepancy for for the
Functional scoliosis.
for the functional scoliosis in relation to?
There are good studies about scoliosis and idiopathic scoliosis and leg length discrepancy. The studies say there is no connection between, you have to see it as two games. Yeah? And leg length discrepancy has no influence on the curve, on a scoliotic curve, on a structural scoliosis. If you have a functional scoliosis, yes, but in a functional scoliosis, you don't give a brace. You make a heel lift, yeah, and look what happened. But there are clear studies, there's no relation. Leg length discrepancy is leg length discrepancy. The pathology is in the epiphysis of the legs, yeah, the asymmetry, and you treat this with your heel lifts and anything, and the spine has another pathology in the sagittal plane. Normally, there are the reasons, and you treat with interventions with the brace. It's clear.
Thank you very much. So, yeah, I have a question for you. Yeah. Different types of brace, whatever you have discussed. Is there any study which covers the effectiveness of or comparison of different braces in a randomized controlled method, or you can say RCT, or minimum group study like more than 30 cases or more than 40 cases in a comparative or effectiveness of different braces?
Yeah, there are studies between Chenot and Boston, clear, in the last centuries. They made studies, good studies, they have a good quality. They are in Scoliosis Journal, open source, available. If I had more time, I can talk about studies the whole days. Good study has about 100 participants, but it's really hard. At the moment, we have in Heidelberg a study that comes in publishing next year about the effectiveness of brace treatment from the university clinic. It's a very good study. We have 120 participants in Chenot treatment. So there come studies, but it's very difficult to make studies about brace treatment. Why? It's clear that brace treatment works. So in our environment, it's forbidden to make a compare between with brace and without brace. It's forbidden. Yeah. So it's clear. Yeah.
Yeah.
So.
Yeah. One more question, please. So you have made some libraries and template, I hope. Did you made from the total body scan or from the measurement, or you have already profile as per your anthropometric data?
As I understand, right, we have library models, 5 basic types, and then we take measurements. We have for our 5 general pattern, we have a special library model, and then we only calibrate this library model to the measurements of the patients and to the functional parameters of bending. So that's how we work normally.
Yeah. How do you make it?
How to get the library? I do it since 35 years. I rectifying cast. When I had a really good cast, I scan it in and say, this is my model for the next year. Yeah. I invest, but I do all the models are handmade, yeah, and are the best of what you do. You do it and you go to the patient and say, wow, this is a really good brace I made. Yeah. this come in my library.
Yeah.
When I see a patient again, I take this model. But it's handmade. You need handmade. You have to know it. No way. Yeah. Sometimes we have Russian visitors or Chinese visitors. They came and asked, "Could we buy your library?"
Yeah.
No. Learn it.
Thank you very much.
Yeah. We sell scanners and mills and everything, but not our library. This is everything. Is my brain. Yeah. Okay.
Yeah. Own templates. Yeah.
Yeah. That's good. But it's a normal way. We all did when we start with CAD/CAM. We start. We do it by cast, and then more and more patient came in the center, and then I was not able to do all the casts, and then I start with CAD/CAM procedure and learn. This is the normal way, but first you have to understand, do it by your hands, and then. But this system, we prove it in human study in the courses since 4 or 5 years, and the students give very good feedback that they are able to learn with this system. They have now a theory, a system to work, and I see it in the follow-ups that the developing, the learning curve of the students in the follow-up over the years, that they learn with this model, and I can talk with them, and this is helpful.
So, numerical solutions, finite element analysis, or Newtonian interpolation, have you compared your model with exact CAD/CAM, your experimental or your personal unique models, libraries?
It was difficult to understand. There was some breaks in your voice. Could you write it? Is it possible in the chat?
Yes.
There's a lot of noise. You asked, have you compared your model with finite element models? Yes, we did. We were the first center in Europe who get the brace simulation software from Rodin and from Canada to work with. While we were the first center who has the 3-dimensional X-ray. For FAM model, you need a 3-dimensional X-ray system to bring the digital X-ray in the model. So we were the first, but we stopped it. Why? For us, it was not helpful, the FAM models. While there is so many, FAM models are bony models, simple models. And for what we see, for most important for us is how the patient react in his posture under the treatment in the brace. And this I can't simulate. This is neurological pathways, posture, and the FAM models are simple models of bones. And we are far away than United States. We know bones are simple. It's a simple structure and it heals without a scar. We know it. But bracing is posture, functionality, movement, walking, sitting, and not bones. Bones are totally stupid structures today, and only help to have distance in the soft tissues. Okay,
Thank you.
Philosophy. Yeah.
was another question coming in that is a matter of reference to this presentation. As I recall, the webinar was recorded, and I would suggest that we probably make the recordings available to the audience as a follow-up, as we are not in the position to circle the full PowerPoint presentations, okay? So, but I think it's a great value for all the participants if the recordings are made available as a, in the following weeks or months to the audience. If you could arrange this, I think we would be happy to go that way. That depends on you, on the institute.
Yeah, I hope we have recorded. Patra sir can tell.
As we have recorded it, we'll give to audience.
Okay, thank you.
Thank you. So, thank you, Mr. Michael, for the wonderful presentation. And really, it was interesting contents. So, I think time is already 5:40. So, we may go for a vote of thanks. Hello. So, my first and foremost thanks to our director, Dr. Amit Iqbal, who, despite his busy schedule, is going with us throughout the program. Sir, our heartfelt thanks to you, and with your blessings, we will continue to conduct many more programs like this. And my thanks to our HOD, who has interacted and also clarified many interesting questions with Mr. Michael. Thanks to Dr. Lenka. So, my sincere thanks to ICRC team, Mr. Naveed and Mr. Anil, for their help to arrange such wonderful speaker. I hope today's topic was interesting for the participants, and in future we will conduct many more such webinars with the help of ICRC and with the help of Mr. Chris from Human Study. Thank you all. Thanks to all participants. Thank you all.
Thank you too. It was nice. Thanks very much.
Thank you.
Have a nice evening, everybody. Yeah. Okay. Bye-bye.
Bye.
Thank you, sir.
Bye-bye.